Good afternoon, everybody. My name is Marcela. I'm a breast medical oncologist here at UT Health San Antonio Mace MD Anderson Cancer Center. And today I have a special guest with us. We're going to be discussing a very pertinent topic. We're going to be talking about fertility. So I have my colleague with me.
Hello, everyone. It's Hatem Azim, an adjunct professor at the Montreal Institute of Technology.
So today we have a very nice presentation from you. Congratulations, by the way. Do you want to fill us in and tell us a little bit more about your study?
Sure. So today we presented the secondary analysis of the positive trial, which is a prospective international single-arm trial investigating the safety of temporary interrupting endocrine therapy to attempt pregnancy in patients with hormone receptor positive early breast cancer. Today we presented the secondary analysis on the use of assisted reproduction and menstruation patterns in patients on this study.
Very nice. And we got very pertinent results that you really give hope for our patients. But I want to emphasize one of my takeaways is it's really important to do fertility preservation from the get-go, because based on your results, patients that have that opportunity to do fertility preservation before they started breast cancer therapy had a better chance of success. Am I right?
Absolutely. I think this is one of the main take-home messages as well of the study. We have shown that those women who underwent transfer of their cryopreserved embryos had the highest odds of achieving a pregnancy on the trial. And indeed, ovarian stimulation, to perform ovarian stimulation or assisted reproduction after having received adjuvant therapy, this is quite tough, because usually the hit that the ovary would take after receiving chemotherapy is usually strong, and the response of the ovary for ovarian stimulation is usually very weak. So of course, the best way is to preserve oocytes or embryos before getting started, and then consider later on to use them or not if spontaneous pregnancy was not feasible. Of course, we acknowledge as well that this is not necessarily feasible for all women to freeze oocytes or embryos. This setup is not necessarily available in each hospital. Sometimes there are insurance issues, but also sometimes as well, in some cases, we need to start therapy quite quickly, and we don't have necessarily the luxury of time to retrieve the oocytes before getting started. That's why this study provides as well some insights regarding the use of other methods and the safety of using other methods as well.
Very nice. And I think one of the big gains as well was kind of debunking that myth when it comes to ovarian stimulation. Some of my patients have expressed fear when they go through the process because of the estrogen surge that they may experience. Do you want to comment a little bit about, disease-free survival specifically for that patient population?
Absolutely. So for ovarian stimulation, we performed this analysis in our trial, looking into women who underwent ovarian stimulation in order to freeze oocytes on embryos before getting started. And in this category of patients, almost 1/3 of patients in our trial underwent this procedure. So we're talking about in the range of 170 or 180 patients. And we did not find an increased risk of recurrence in these patients compared to others who did not undergo this procedure. We're talking about around 9.7% risk of recurrence at 3 years, compared to 8.7% in those who did not undergo. Of course, the regimen used to stimulate the ovary differ, and the group of Kutluc-Okta in New York have really worked hard on defining a regimen that avoids this estradiol surge that you were referring to, predominantly in order to make us more comfortable with using this regimen in the context of early breast cancer. And this is pretty much by adding letrozole to gonadotropins. And this have been shown not to compromise the oocyte yield, but certainly associated with a much lower estradiol level during the period of stimulation.
Very nice. And we also had a very nice presentation by Dr. Lambertini in patients that carry germline BRCA1 and BRCA2 mutations, and their outcome when they got pregnant after their breast cancer diagnosis. Any comments on his work today?
Well, this is definitely a very important study that was conducted in some 5,000 patients or 4,600 patients. Who became pregnant after breast cancer diagnosis. All of them were BRCA mutant. Mm-hmm. Around 600, 700 patients had a pregnancy, and the others served as control. And the study had a median follow-up of around 7 years. Mm-hmm. And the main take-home message of this study that there was no detrimental effect or there's no worse prognosis in women who became pregnant after breast cancer diagnosis compared to the control group, which further emphasizes the safety of pregnancy in these patients and that pregnancy should not be discouraged in women who completed the adjuvant therapies.
Very nice. And, this afternoon we have another session that discusses the use of taxanes in patients that are pregnant and they're dealing with breast cancer. And definitely I will finish our discussion by quoting Dr. Lambertini at the end of the presentation today, that he said that there is always hope after breast cancer. So thank you so much for joining me today. And I hope the rest of you continue to enjoy the symposium and continue to learn. Thank you so much.
Thank you.